Hello friends, today we're going to discuss about Clozapine-Resistant Schizophrenia. I'm Dr. Suresh Badadmat, Professor of Psychiatry, working at National Institute of Mental Health and Neurosciences, Bangalore. In this video, I'll be discussing about definition of Clozapine-Resistant Schizophrenia, prevalence, predictors, and management of Clozapine-Resistant Schizophrenia. Schizophrenia is a heterogeneous disorder which is caused by multiple factors. It can be genetics, it can be environment, it can be neurochemical hypothesis, and various factors have been attributed to development of schizophrenia. Schizophrenia is severe mental disorder which affects lifelong, required to be medication for long duration of period, and affects 1% of the world's population. Schizophrenia is characterized by positive symptoms, negative symptoms, and cognitive symptoms also. Schizophrenia causes severe disability, biological, social, and occupational dysfunction. Unfortunately, not all patients with schizophrenia respond to medication. Approximately 25 to 35 patients of schizophrenia do not respond to medication. In treatment-resistant schizophrenia, clozapine has been advocated as a gold standard medication. Even FDA from US has indicated clozapine is the treatment of choice in treatment-resistant schizophrenia. Even if you give clozapine for treatment-resistant schizophrenia, only 40% of them will respond to clozapine. 60% do not respond. That means these are those patients who are called as clozapine-resistant schizophrenia. If you take 100 schizophrenia patients today and you start antipsychotics, for the first antipsychotic, 50 to 60% will respond. Still, there is 40% who do not respond. Hence, you need to start second antipsychotic. Again, after starting second antipsychotic, there will be a response up to 10 to 20%. That means in total, 35 to 40% do not respond to two antipsychotics. Hence, you need to consider clozapine. That means these are the 30% of treatment-resistant schizophrenia who will be started with clozapine. After starting clozapine again, 20 to 15% do not respond. Hence, we may have to start augmentation of clozapine either with ECT or else any other antipsychotics. In spite of that, 10 to 15% do not respond to even clozapine and any other augmentation strategy. These are those patients who are called as clozapine-resistant schizophrenia. Let's understand with this simple diagram. Today you take 100 schizophrenia patient, start on antipsychotics. In spite of two antipsychotics over a period of 6 to 12 weeks, 30 to 35% do not respond. Hence, you will give clozapine. Even after clozapine, 20 to 25% do not respond. They are considered as clozapine-resistant schizophrenia. Further, when you augment clozapine with ECT and other atypical antipsychotics, still around 10 to 15% do not respond at all. They are called as refractory schizophrenia. Let's define treatment resistance and clozapine-resistant schizophrenia. Clozapine-resistant schizophrenia means approximately 15 to 20% of the patient with schizophrenia will not respond to clozapine also. And these are called as ultra-resistant schizophrenia or clozapine-resistant schizophrenia. They are also called by various terms such as ultra-treatment resistant, clozapine-resistant schizophrenia, clozapine unresponsiveness, clozapine partial responder, clozapine resistant, ultra-resistant schizophrenia, super refractory schizophrenia. Various terms have been attributed to this. ultra treatment resistant schizophrenia is defined as the persistence of either positive, negative, or cognitive symptoms of schizophrenia after at least with moderate severity of symptoms with adequate duration of clozapine trial with adequate dosage. That is considered as ultra treatment resistant schizophrenia. If you look at the first episode, treatment resistant schizophrenia, they can be categorized into two. The first one is treatment unresponsive from the first episode. The second one is treatment unresponsive after multiple episodes. These multiple episodes occurs because of poor drug adherence, substance abuse, and also treatment resistance which can occur. Hence, my dear friends, these two categories over a period of time leads to clozapine-resistant schizophrenia. Let's understand this clozapine-resistant schizophrenia from the definition for the purpose of research. If a treatment-resistant patient did not respond to clozapine for 3 months with the therapeutic dosage of 300 to 600, here the clozapine plasma concentration should be in the range of 0.35 to 0.5 milligram per liter. In simple word, 350 nano per liter has to be there. In this regard, Mufak and colleagues gave a multidimensional criteria for clozapine-resistant schizophrenia. As per the Mufak and his colleagues, this multidimensional criteria for clozapine resistance, it starts with at least 8 weeks of treatment with clozapine with the plasma level of more than 350 milligram per liter and failure to improve at least by 20% on total BPRS scores. Further, persistent psychotic symptoms defined as more than score of 3 on at least 2 of the 4 positive symptoms items on BPRS score. Current presence of at least moderately severe illness on BPRS, that is score than more than 44, and a score of more than 3 on clinical global impression and severity rating scale. Persistence of illness as defined as no stable period of good social and or occupational functioning within at least past 5 years, that is inability to maintain work and relationship, and global assessment of functioning is less than 40. To summarize, as per the Mufak et al., the treatment resistance with regard to clozapine can be defined as adequate dosage, that is plasma level of more than 350 nanogram per ml, adequate period of 8 weeks, no significant improvement, that is less than 20% decrease in symptoms on BPRS score, symptoms presence, that is BPRS score more than or equal to 45 on at least 2 of the 4 positive symptoms on BPRS, duration of illness with poor functioning for at least 5 years has been indicated to define clozapine-resistant schizophrenia. Now let's understand what are the predictors for non-response to clozapine. In over 300 studies with regard to predictors of clozapine response, the consistent predictors have not been found in any of the studies. Some reviews have concluded there are no reliable factors predicting clozapine response or resistance. Because of the inconsistent result and methodological uncertainties, and also the definition of clozapine resistance has not been uniformly defined across studies. Hence, it is difficult to compare. However, the few studies have found that the predictors of non-response are old age, greater severity of symptoms, especially negative symptom severity, poor functioning, premorbidly poor functioning, non-paranoid subtypes could indicate clozapine response, that is non-response. Research also suggests history of catatonia, smoking more than one pack per day, increased sedation, cognitive deficits also indicates non-response to clozapine. Nicotine, that is non-response to clozapine, emphasizes its ability to induce cytochrome P450 enzyme, and this reduces serum clozapine level. Smoking more than 20 cigarettes per day increases the risk of non-response with regard to clozapine 5 times after adjusting to the effect of age, gender, and serum clozapine level. That means, my dear friends, if a patient is smoking and is on clozapine, his clozapine levels will be very less. Hence, you need to adjust the dosage for 350 nanogram per liter, my dear friends. An important study published by Sandeep Govar and his colleagues in 2002 in Journal of Clinical Psychopharmacology. The title of the study said that factor associated with poor response to clozapine in schizophrenia, a study from northern India. In this study, they looked into the predictors of non-response to clozapine. Since it is an Indian study, it clearly indicated some of the important predictors indicating poor response, such as unemployment at the time of starting clozapine, longer duration of untreated psychosis, received higher number of antipsychotics before starting clozapine, having polypharmacy with regard to treatment of schizophrenia, many medical comorbidities, psychiatric comorbidity, having visual hallucination, having maid phenomena such as maid affect, maid act, maid feeling indicated poor response, higher clinical global impression severity score indicated poor response to clozapine. Now let's discuss management of clozapine-resistant schizophrenia. Here, Chakrabarti 2021, in a study with regard to clozapine-resistant schizophrenia, how to do the management, he published this article in World Journal of Psychiatry. In this World Journal of Psychiatry, he described various steps. The first step, he talked about adequate assessment, proper dosing of clozapine, adequate duration of clozapine to be given, managing side effects of clozapine, managing non-adherence to the medication, collaborating with parents of the patient and also the caregivers, addressing clinicians-related barriers play a crucial role in clozapine-resistant schizophrenia management. Hence, let's discuss each one of the steps. As soon as we get clozapine-resistant schizophrenia, we need to do the reassessment with regard to diagnosis, presence of comorbidity, any other diagnosis such as OCD, depression, personality disorder, substance use. The next step is to optimize clozapine level. You need to optimize the clozapine concentration of plasma in the range of 0.35 to 0.5 milligram per liter, my dear friends. Further, you need to consider trial of supratherapeutic clozapine. If the patient is able to tolerate clozapine well and he does not have major side effect, please do increase clozapine up to 600 to 900 mg. The simple reason is clozapine is the last drug which has given some hope. If the patient does not have any side effect, please do consider supratherapeutic dosage of clozapine. You need to give at least adequate duration of 8 to 12 weeks. Further, you need to manage side effects proactively. Ask the patient for regular follow-up and also look for development of any side effect. You need to augment, especially if the patient partially responds. If there is no improvement, then you may have to consider other strategies. You also need to look into psychiatric comorbidities. Consider treating these psychiatric comorbidities aggressively. If you find a patient having OCD as a comorbidity, please do start SSRI and CBT. If the patient has depression, please do consider SSRI and CBT. In case of hypomania, substance use, please do consider valproate and other medications. You need to also consider psychological therapies such as CBT and family intervention in clozapine-resistant schizophrenia. With regard to clozapine resistance, we have three important approach. The first approach is augmentation or combination of medication. The second one is ACT. And finally, psychosocial treatment such as CBT and family intervention. An important study published in European Psychiatry by Boyuk and his colleagues in 2020. The title of the study is Clozapine and Paliperidone Palmate Antipsychotic Combination in Treatment-Resistant Schizophrenia, a retrospective 6 months mirror image study. A preliminary study with regard to combination of paliperidone with clozapine clearly indicated that this can have an effective combination and safe and can show improvement, suggesting further research with randomized control trial of augmenting clozapine with paliperidone palmate can play an important role in breaking the nexus of clozapine resistance. Another important study by Bartoli and his colleagues in 2018, published in Journal of Psychiatric Research, has a title of Adjunctive Second Generation Antipsychotic for Specific Symptom Domain of Schizophrenia-Resistant Clozapine. A meta-analysis was done. Bartoli and his colleagues did a meta-analysis which included 12 RCTs, which included first generation antipsychotic and second generation antipsychotic. Here in this study, the main objective was to test the efficacy of adjunctive second generation antipsychotics for main symptom domain, that is positive, negative and depressive symptom domain in individual with clozapine resistant schizophrenia. The result highlighted the lack of efficacy of second generation antipsychotics as an add-on treatment for positive symptoms, and a small benefit with regard to second generation antipsychotic was estimated for both negative and depressive symptoms. This study concluded further RCTs are needed to establish efficacy and tolerability of second generation antipsychotics added with clozapine. Evidence from the current meta-analysis and meta-review indicates only there is a marginal improvement or else low quality evidence indicates benefit of combining clozapine with second generation or first generation antipsychotics. That is better than monotherapy of clozapine. Despite the marginal benefit of clozapine combination with other antipsychotics, although you have to be very careful in combining. However, in everyday practice, you can see many patients who do not respond to clozapine or a partial response to clozapine, we do add various other antipsychotics. It can be first generation or maybe second generation antipsychotics. These are the common clinical practice. A systematic meta-review of available evidences and international expert consensus guideline, which was done by Wagner and his colleagues with regard to augmentation of second generation antipsychotics and first generation antipsychotics, can be beneficial with regard to clozapine augmentation. However, the supporting evidence are from a low quality studies. That means we require strong RCTs to say clozapine combination with first generation antipsychotic and second generation antipsychotics yields better results. Those studies need to be done. However, whenever you combine clozapine with any other antipsychotics, side effects are well known. Especially clozapine related side effects need to be counteracted by adding other antipsychotics. If you want to have a least metabolic syndrome or else clozapine induced metabolic syndrome is there, the best to combine with aripiprazole. If the patient has clozapine induced seizure, please add valproate. If the patient has salivation, please do consider adding amitriptyline. If the patient has low WBC count, consider adding lithium. If the patient has depression or OCD symptoms, consider adding fluoxamine. If the patient has pseudo-resistance or poor drug compliance, or if you have a doubtful compliance, please do consider long-acting injectables, especially paliperidone. In this regard, combination with lamotrigine has been studied with clozapine very well. Theonin and his colleagues did a study with regard to meta-analysis of 5 RCTs comprising 167 participants. Combination of lamotrigine and clozapine was studied. This meta-analysis suggested that lamotrigine augmentation may be an effective treatment for patients with clozapine-resistant schizophrenia. A substantial proportion of those patients who are severely ill appear to obtain clinically meaningful remission after combining clozapine and lamotrigine. Similarly, topiramate was considered. However, a couple of open-label trials showed improvement, but few studies did not show any improvement. There is a need for large-scale prospective RCTs with regard to topiramate. That is the present understanding with regard to combination of clozapine and topiramate. Further, there are open-label trials, case reports, and practical clinical experience suggest that combination of clozapine and olanzapine can be considered. Combination of clozapine with risperidone. It can also be considered with amisulpride, ziprasidone, aripiprazole, and quetiapine can be considered. However, clozapine combination with various antipsychotic drugs in treatment-resistant schizophrenia, a Cochrane review done in 2017 highlighted some of the aspects. Here, they came up with an important recommendation. Aripiprazole combination with clozapine has fewer side effects. Amisulpride and ziprasidone combination with clozapine may produce better short-term clinical response than quetiapine. Risperidone may be superior to amisulpride and ziprasidone in reducing symptoms after combining with clozapine. However, the data is not of high quality. These are of poor quality studies. And the studies which have high quality are few in number and participants are also few. Comparing head-to-head trial are very less. Clinicians need to use their clinical judgment for choosing add-on therapy based on comorbidity, patient's tolerance with the medication, affordability of the medication, and choice of the medication. At this point of time, combination of clozapine with either first-generation antipsychotic and second-generation antipsychotic, the evidence is very weak. Although various clinical guidelines do recommend combination. In this regard, an important study published in Turkish Journal of Psychiatry by Vayasoglu and his colleagues. The title of the study was Augmentation of Antipsychotic Treatment with Memantine in Patient with Schizophrenia, a Systematic Review and Meta-Analysis. In this, author analyzed 11 double-blind randomized placebo-controlled trial of memantine 10 to 20 mg per day in combination with clozapine given to 570 patients. And here, many a time, the patient also received various atypical antipsychotics. It can be quetiapine, risperidone, olanzapine, ziprasidone, and various other medication. Memantine augmentation treatment is beneficial for treating particularly negative symptom of schizophrenia was the study's result. Along with this memantine, now we will move to electroconvulsive therapy in ultra treatment-resistant schizophrenia. ECT is reported to be very important treatment with regard to clozapine-resistant schizophrenia. Various studies have clearly indicated adding ECT for clozapine-resistant schizophrenia has found to be improving in with regard to positive symptoms and to some extent negative symptoms. However, the study evidence are limited to some extent. In this regard, there was a Cochrane review with regard to electroconvulsive therapy for treatment-resistant schizophrenia. And here in this Cochrane, they give certain important observation. The point number one, 50% of patients with schizophrenia who fail to respond to medication respond to ECT. The largest improvement occurred between the third and sixth ECT, with plotting of ECT effect after sixth session. Cognitive outcomes improved over a period of time. There was no significant improvement in quality of life outcome after adding ECT. We were unable to find any factors that were significantly associated with treatment response in clozapine-resistant schizophrenia. Further, adding cognitive behavioral therapy in clozapine-resistant schizophrenia. CBT has been extensively used in patients with treatment-resistant schizophrenia, in patients with having predominantly delusion or else hallucination. A meta-analysis of 12 randomized control trial showed that when compared with controls, patients with medication-resistant psychosis who have received CBT showed significant improvement. But however, the patient need to cooperate cognitive behavioral therapy. Availability of cognitive behavioral therapist also adds to the challenges. However, giving therapy in a clozapine-resistant schizophrenia is a big challenge. Patient may continue to have symptoms and may not cooperate the therapy. Further, among non-pharmacological augmentation strategies, CBT has been investigated in multiple randomized controls trial, and these studies have indicated the efficacy of CBT after augmenting clozapine. Now let's look into the recent meta-analysis which have been published. One of the important study published in Asian Journal of Psychiatry in 2023 by Chuan et al., where the study title was Pharmacological and Non-Pharmacological Augmentation Treatment for Clozapine-Resistant Schizophrenia, a systematic review and network meta-analysis with normalized entropy assessment. In this study, they conducted a network meta-analysis to integrate all evidence derived from randomized control trial of pharmacological and non-pharmacological augmentation intervention for clozapine-resistant schizophrenia. Here, authors identified 35 RCTs comprising of 1,472 patients with 23 active augmenting agents or treatments. In this systematic review, they found certain important findings. They were definitely stunning. Mirtazapine, ECT and memantine were ranked the best 3 augmentation treatment for overall improvement in symptoms in clozapine-resistant schizophrenia. ECT was recorded as the second best improvement with regard to positive symptoms. Memantine, duloxetine and mirtazapine were ranked as the best for negative symptoms. All antipsychotics, antiepileptics, and NMDA receptor agonists were not associated with any improvement compared to placebo. And here the symptoms did not improve were positive symptoms, negative symptoms, and cognitive symptoms. Another important study published by Sandeep Grover and his colleagues in Acta Neuropsychiatrica. The title of the study is Augmentation Strategy for Clozapine Resistance, a systematic review and a meta-analysis. This study reviewed the systematic review and meta-analysis of 45 RCTs that have evaluated the clinical efficacy of various pharmacological agents, non-pharmacological strategies, somatic treatment like ECT, RTMS as an augmenting agent to clozapine. The result indicated that clozapine non-responsive patient responded maximum to mirtazapine and clozapine combination, The second was clozapine and ECT combination. Third one is clozapine and aripiprazole combination. And finally, clozapine and risperidone combination. That means, my dear friend, mirtazapine was a sudden entry, and various meta-analysis are indicating combination of clozapine and mirtazapine should be tried. Now let's look into the various research molecules. One of the newest molecule is cariprazine in the dosage of 1.5 milligram, 3 milligram, 4.5 milligram and 6 milligram can be combined with clozapine to see whether there is an improvement or not. Here cariprazine is given once a day dosage. Similarly, another important drug, brexpiprazole, given once a day, either 0.5 mg, 1 mg, 2 mg or 3 mg can be considered in combination with clozapine. Braloxazine also can be combined with clozapine. 15 mg, 30 mg and 50 mg OD dosage can be given. However, these drugs are still in research with regard to clozapine-resistant schizophrenia. However, there is no harm in trying low dosage of these novel antipsychotics with clozapine. Further, the initial studies from pimavanserin and loperidone have found that they can improve negative symptoms. Pimavanserin in a dosage of 17 to 34 milligram in combination with clozapine can be considered. Similarly, roloperidone with the dosage of 30 to 64 milligram per day can be considered. Other drug efficacy for positive and negative symptoms of schizophrenia, such as ulotorrent, xanomeline, can be considered. NMDA or glycine modulators such as glycine, D-cycloserine, D-serine in the normal dosage, high dosage have also been considered for cognitive and negative symptoms. Few open label trials have found efficacious, but some trial did not show any improvement. Memantine 20 mg per day has found to be very useful with regard to negative symptoms on combination with clozapine. Summarizing, various strategies for clozapine-resistant schizophrenia will be discussed now. The treatment-resistant schizophrenia, especially clozapine-resistant, 15 to 20% of schizophrenia patients are clozapine-resistant. They are also called as ultra treatment-resistant schizophrenia. Treating clozapine-resistant schizophrenia is challenging to any psychiatrist. ECT augmentation can be tried. Novel agents can also be combined. Combination of clozapine and mirtazapine can be tried. There is an urgent need to invest in clozapine treatment-resistant schizophrenia research. With regard to augmentation, please do consider mirtazapine as a first step, ECT as a second step, memantine can be the third. If there is no improvement, ECT up to 6 to 8 can be considered. With regard to negative symptoms, combination of clozapine and memantine, duloxetine and clozapine combination, or mirtazapine and clozapine combination can be tried. Add on second generation antipsychotics such as amisulpride or risperidone or olanzapine or quetiapine along with clozapine can be considered. Add on second antipsychotic with significant different receptor profile such as aripiprazole or cariprazine with clozapine can be considered. Finally, if there is no improvement, high dose clozapine, if the patient is able to tolerate, please do consider giving from 600 to 900 mg. And you need to watch for seizures. If the patient develops seizure, please do consider adding valproate and continuing clozapine. The simple reason is clozapine is the only drug which has been found to be very useful in treatment-resistant schizophrenia and also clozapine-resistant schizophrenia. Psychosocial treatments such as CBT and family intervention can be considered. Other novel antipsychotics, dopamine receptor occupancy such as xanomeline, tropicium, sodium benzoate, D-amino acids can be considered in clozapine-resistant schizophrenia. Thank you very much for giving your valuable time. Stay safe.